The goal of this presentation is to discuss the anatomy which is relevant to know in scanning subscapularis tendon. The rotator cuff is a major active stabiliser of the humeral joint. The rotator cuff consists out of the subscapularis, the supraspinatus, the infraspinatus, and the teres minor. The rotator cuff originates as 4 independent muscles, but inserts as a common tendon. Boundaries between structures are not clear. There is a very large degree of interconnection between all fibres at the level of the greater tubercle. This has strong implications for scanning and clinical reasoning. The subscapularis is located on the anterior aspect of the shoulder. The fibres of its muscle lies in the subscapular fossa of the scapula. Most fibres are directed upwards and laterally, running under the coracoid, anterior to the glenohumeral joint, and insert onto the lesser tubercle of the proximal humerus, with some superficial fibres, also named as transverse humeral ligament, bridging the intertubercular groove and attaching to the greater tubercle. The anterior part of the scapula, the subscapular fossa, is very smooth. The subscapularis muscle itself is very thick and strong. How does such a big, strong subscapularis hold onto the smooth scapular bone? The answer to that is the subscapularis containing many intramuscular aponeurosis and tendons which internally reinforce the whole muscle and maximise the strength of the muscle. These different tendon fascicles can also be seen with ultrasound and should not be mistaken for pathology. The coracoid process becomes a region of interest when scanning the subscapularis. For example, to observe the subscapularis gliding during internal and external rotation. During this movement, there could be a friction between the subscapularis and the coracoid process, a subcoracoid impingement. Subcoracoid impingement pain is thought to be caused by impingement of the subscapularis and bursal structures between the coracoid and the lesser tuberosity. In progressive diseases, subcoracoid impingement syndrome has also been associated with subscapularis tendon tears. A key finding in subcoracoid impingement is a decrease in the subcoracoid space with the arm in internal rotation. This has implications with respect to the diagnosis, symptom generation, and management of subcoracoid impingement. This slide is showing 3 types of coracoid: A, flat, B, hooked, and C, with an osteophyte at the tip of the coracoid. The coracohumeral distance indicated by the white arrow determines the susceptibility to subcoracoid impingement. The coracoid process shows anatomical variances, like, for example, the coracoid root angle. This angle indicates how steep the long axis of the coracoid process is. So if you can't find the coracoid process in its most regular place, just sweep the transducer a bit more to the proximal. There you will find it most likely. Please keep in mind that a steeper coracoid root angle has consequences for clinical reasoning. The coracoid process is an important landmark and an attachment site for many structures such as muscles, ligaments, and also the subcoracoid bursa. The subcoracoid bursa is located between the coracoid process, the conjoint tendon of the biceps short head, and coracobrachialis and the subscapularis. The bursa minimises the friction between the coracoid and the subscapularis. The subcoracoid bursa occasionally communicates with the subacromial bursa and merges with the superior subscapularis recess, known as subscapularis bursa. Please don't forget the relationship between subscapularis tendon and its course over the intertubercular groove to provide stability for the long head of the biceps tendon. When scanning the subscapularis tendon, be prepared, if affected, to see the subacromial subdeltoid bursa or the subcoracoid bursa.